I am Blythe Lord. I am the founder and executive director of Courageous Parents Network. I'm joined tonight by several staff and colleagues. I shouldn't call them staff, colleagues from Courageous Parents Network, fellow mom Jennifer Seidman, pediatric psychologist Chrissy Sally, Allison May, who does all sorts of things at CPN, and of course, our special guest, Dr. Aliza Olive. We're here to talk about this issue of fear of regret in the context of decision making when you are parenting a child living with a serious medical condition. This is a topic we have done other in the rooms on decision making because it is a chronic condition. Decision making is a chronic condition for actually for being human. It's also a chronic condition for parenting any child, and it is a condition on steroids when you are parenting a child with a serious medical condition where you are often having to navigate so many decisions about their medical care, medical interventions, and also how do you and your family choose to spend your time. So allocate decision making around work, in the house, out of the house, just all sorts of things. There are so many ways that decision making feels particularly charged when your child has a serious medical condition and often a life limiting condition. My daughter Cameron was only ever going to have a very short lifespan, so we wanted her life to be as good as possible for those what it turned out to be 2 years. So when you only have 2 years, what are those decisions that you're making? And I'm pleased to say we don't regret any of the decisions that we made, but some of them involved a lot of thinking, a lot of time, a lot of thinking, a lot of conversations with our primary care pediatrician, who was also very palliative minded. This is a long-winded way of saying that this is what we do all day long as parents, and this is what we at CPN are always thinking about on your behalf. So we're really delighted that Dr. Aliza Olive, who has done research in this space, is here to join us for this conversation. You can put your questions in the chat. When Dr. Olive finishes, we will go to direct questions from you. You can raise your hand and unmute yourself and ask, and we'll just take it from there. So thank you, Aliza. Welcome, and please.
Thank you so much. I'm going to pull up my slides while I start introducing myself. I am very excited to be here. Thank you so much. Let me make sure I'm doing this correctly. We just had a tutorial. Did I do a good job?
No, you got it not right.
Not right. Okay. See,
it's okay. You just have to share your deck, and then, go. There you go. You got it. Perfect.
Okay, technologically challenged. I apologize. So as Blythe mentioned, I'm Aliza Olive. I am a pediatric intensivist at Cleveland Clinic Children's, and I have a particular interest in bioethics. And she asked before the talk started for me to talk about a little bit how I became interested in this topic. And it really started when I was a first-year pediatric intensive care fellow on the cardiac ICU. Some of the children with congenital cardiac anomalies do really, really well, and some of them do okay after a long period in the hospital, and some of them don't have as favorable outcomes. And as I was rotating through that ICU, I started just wondering what the consent process was like and what was discussed with these families prenatally, and as they went through the process, wondering how much information they got about how challenging their time could be. There were kids that spent 18 months in the hospital before ever going home. There were kids who spent 18 months in the hospital and then died. And I just wondered, how much information did they get, and how do these parents feel with what information they got about decision-making that they went through. So as I finished training and started my job that I'm at now, I'm working on starting a study looking at decision regret and decisional conflict in the congenital cardiac population. So that's sort of how I ended up here. But as I said, I'm really honored to be talking with all of you today. So just a little overview about sort of the flow of what I'm going to talk about. We're going to start with just a brief introduction on what decision regret is. I'm going to go through a little bit of the literature that's out there. There's not much. An example of a parent talking about decision regret, because I'm obviously coming at this as a clinician and not the parent of a child with these types of decisions being made. And then decision regret prevention and managing decision regret once it has happened. And then how us as clinicians behave and interact when these big decisions are being made, and just some points about decision aids. And then we'll talk about some big takeaways for parents. So what is decision regret? There we go. So it's negative emotions or dissatisfaction that someone feels after they make a decision. It's thought to be most associated with outcomes that are not as expected, or when somebody believes a different decision might have led to a better outcome. And this can be in our personal lives, this can be professional decisions, and then for the case that we're talking about here, more medical decisions. It's an emotional response that can involve feelings of sadness, disappointment, guilt, or frustration. And it's often when we're comparing to alternatives and driven by the belief that a different choice would have resulted in a more favorable outcome. And it often happens when we're focusing on the consequences of the decision rather than the decision-making process that we went through. In medicine, when we think about decision regret, it's often in terms of treatment options or health behaviors, and it can be influenced by information availability, whether we have limited information at the time of making the decision, that can certainly increase the likelihood of regret. Outcome uncertainty, unpredictable outcomes, or high stakes decisions can potentially lead to greater regret. Personal values and goals, so misalignment between the decision that's made and one's core values or long-term goals. And social influence, pressure from family, friends, or society can lead to decisions that are regretted later. There's also quite a bit of psychological impact that comes along with decisional regret. Stress and anxiety can come from decisional regret, and it's actually, we'll talk later, been shown that anxiety can also lead to decision regret. It can lead to decreased life satisfaction. When there's persistent feelings of regret, it can reduce overall satisfaction and happiness. And later, indecisiveness. If you experience decision regret, fear of future regret can lead to more indecision or overall avoidance of decision making entirely. In terms of the literature, what we know out there from the medical research about decision regret, there's very little. There's mostly papers in the pediatric oncology sphere. And then outside of that, there's a handful of general papers. I'm working on one for the congenital cardiac population, but otherwise there's not much more generalizable data. I'm going to run through a couple of the papers that are out there, mostly for the purpose of pulling out some themes that we can talk about. This first paper is about decision regret in parents of children with cancer. We know that barriers to informed decision-making exist, and the goal of this study for this group was to evaluate whether parents feel satisfied with or regretful of decisions that they made for their child's cancer treatment, and then to look for factors associated with increased regret. So these parents were surveyed within 12 weeks of their child's initial cancer treatment decision using a decision regret scale. And 16% of these parents had heightened decisional regret. And the group found that race and ethnicity were associated with regret, and that high quality information and detailed prognostic information, as well as having a trusting relationship with the oncologist, were associated with lower regret. This next study was of parents of children, again, with cancer, making treatment decisions in highly emotional states. And And they went into this study knowing from previous studies that 1 in 6 parents demonstrated heightened decisional regret regarding treatment at diagnosis. That was that previous study. And the goal of this study was to look at regret evolution over time. So these parents were given questionnaires at the time of diagnosis and then 4 months and 12 months out. 13% of parents reported regret at the time of diagnosis, and that went down to 11% at 4 months and was again 11% at 12 months. They again found that heightened regret was associated with being non-white and then having high anxiety. And they found that lower regret was associated with high peace of mind and those reporting high quality information. This next study was meant to identify factors associated with and explain patterns of decisional regret, again, in the cancer population, about 6 to 24 months after a child's death from cancer. So this group asked about regret and decisions during the end of life time period, and 38% of these parents reported decisional regret, while 49% reported no regret and 12% were unsure. And then they looked at associations again here and found that increased regret was associated with parents who perceived greater suffering at the end of life, as well as self-blame and difficulty reconciling treatment choices with the outcome. And they found that preparation for symptoms was associated with a decreased risk of regret, as well as balanced teamwork that warned parents on what to expect and how to make meaningful memories. This study is actually outside of the cancer population. So this is the study that inspired my congenital cardiac study. It is looking at parental conflict, regret, and impact on quality of life in families who undergo tracheostomy placement. So they studied these families at the time of decision and then 2 weeks and 3 months after the decision. And 90% of the participants expressed decisional conflict, mostly from feeling uninformed and pressured to make a decision. And then 52% expressed regret at 2 weeks and 72% expressed regret at 3 months. And then there's a bunch of quotes and everything that are in here, but the main themes for causes of regret included feeling uninformed, ill-chosen timing of the tracheostomy placement, perceptions of inadequate medical care, and then they found that quality of life was impacted by the overwhelming medical care and complexity of caring for a child with a tracheostomy, as well as financial burden and the effect on the parent's psychosocial health. And so these are just some of the quotes that went along with those themes. And so this is the last study I'm going to talk about in this part, but this is a study of bereavement regret of parents, again, who had a child that died of cancer. And they used a more open-ended exploring questionnaire that was sent at least 6 months following the child's death. And so it included these 4 questions. I'm really sorry. My husband left the house and my daughter's calling him. I'm just going to tell her to come downstairs. I really apologize, but she's...
Okay. That's okay. I am...
Come down here, babe. Come here. Daddy went to take...
One of the reasons that we encouraged Aliza to share some of this research is it contextualizes what feels like a very personal to you all by yourself situation in the context of a larger population of other parents of children with different conditions or perhaps similar that have warranted study. Like, this is so important. It is recognized that it is so important that people are studying it because it matters. And I just want to note this. We'll move into okay. Aliza, we welcome your daughter sitting on your side if that's what needs to happen.
Okay, turns out he's here. I thought he wasn't home because she was calling, and it's totally fine.
Okay.
So anyway, they sent out this questionnaire that has been on the screen, so I'm sure everybody read it. But they found that regret experiences were shared by almost all of the participants, and the focus of regret included parenting and interaction with the child, reflection on existing values, dealing with the disease, and neglecting the remaining siblings. And so they pulled four major regret themes from this study: dealing with the child, shift of appraisal, dealing with the illness, and siblings. Very few of the parents that responded to this survey stated no regret, and those respondents focused on their stable, close, and loving relationship with their child, which enabled them to consider the time spent together as a gift. And they were able to focus more on the positive aspects and memories and look at the entire life of the child, which I think is similar to what you were talking about before we started, Blythe.
Yeah.
So I just thought that was interesting.
Yeah.
This is actually a blog post that was on the Courageous Parent Network website very recently that everybody brought to my attention. So this family wrote the blog post. They actually had 2 children with Sanfilippo syndrome, and they were about 3 years apart in age, and both children ended up with feeding intolerance. And I'm just going to share 2 of the salient quotes from that because I thought they were important to mention. So she wrote, "I spent a significant amount of time perseverating on our decision to stop feeding her. I would be rendered inconsolable and overwhelmed with guilt. My husband would walk me through the events, logically laying out the cause and effects and why we came to our decision. Repeatedly organizing the facts allowed my emotional responses to quell. I needed that framework to assuage any guilt and confirm the decisions were made to alleviate the suffering of our daughter. We noticed the signs earlier and knew that what adjustments to make. Our medical team was also more versed, having navigated Waverly's decline with us just 3 years prior. The decisions came quicker and with a tinge less doubt. As parents of children with rare diseases, we are often the experts in the room, explaining the nuances of our children to those more credentialed than we are. We bring binders and share literature to inform those caring for our children. We were fortunate to have a medical team who invited us to have a seat at the table for all decisions. And if they weren't open to that, we found another provider who was willing to say, I don't know, and let me consult with others."
Mm-hmm.
And so I think that ties in with the themes that I pulled from the literature really nicely. Regret is common. That's the first thing. I think people probably think when it's happening to them that they're alone and nobody else questions decisions that same way. And that's just not true. And I think what we can take from it is that increased regret is generally associated with non-white families, anxiety, perceived suffering at the end of life, feeling uninformed, and feeling pressured to make a decision. And the literature shows a lack of regret being associated with high peace of mind, quality information, preparation for symptoms, balanced teamwork, knowing what to accept, and meaningful memories. So that allows us to think a little bit about how to prevent regret, or at least minimize it as best we can. One of the first things is to gather comprehensive information. We as a healthcare team, and I mean we being me and people on my side of the table, need to encourage families to gather as much information as possible about their child's condition and treatment options. It's important for us to ask questions and seek second opinions if needed, as well as resources, including support groups. Involving the child when appropriate. If your child is old enough and has the ability to understand what is going on, involving them in the decision-making process can really help ensure that their preferences and values are considered. We need to help families identify core values and priorities by finding out what's most important for their child's quality of life, and that will also help guide decision-making. Seeking support. Families should seek emotional and practical support from healthcare providers, counselors, and support groups. I think talking to families that are in similar situations or with similar diagnoses can help, and discussing options and feelings with others who understand your situation can help provide clarity and reassurance. Take time when it's possible. It's okay to say, I need more time. Obviously, in a more acute situation, if it's not an option, that's one thing. But if it's not urgent, then say, I need more time, because we know rushed decisions lead to regret. And then make memories. This is sort of in both the prevention and the helping with regret, because it came up on both sides in the literature, but using resources for that memory making, going on the vacation when you can, doing the best you can to have those memories. My favorite team in the hospital is our palliative care team. I've always just had a great relationship with them. I try to involve them as soon as I can in any kid that has a chronic diagnosis coming up. I just think that they are such an amazing bridge between my ICU team, the consulting services, and the family, and they really just help bring everything together. And I think they have a really big role in preventing regret as well. First, they provide detailed and clear information about your child's condition, treatment options, and potential outcomes, which can contribute to well-informed decisions. They help facilitate open and honest conversations, and they help make sure you understand the choices and the likely scenarios. They're also able to help understand your values and preferences and the goals of your family, which enables a more personalized approach to make sure the decisions align with what's most important to you. They provide a level of emotional support, helping families navigate through the stress and anxiety that's associated with decision making. Palliative care teams also help promote shared decision making, ensuring that you as a family are actively involved in the decision process, and they help balance the medical recommendations with those family values and preferences, ensuring that we really have a collaborative decision-making process. And then they help with that memory making that's so important.
Mm-hmm.
In terms of managing regret, we know that, while it's impossible to not have any regret at all, we can try and manage that regret once it does occur. As I mentioned before, it's important to realize that these feelings are normal, and it's a common experience among caregivers of children with chronic illnesses. And it's important to accept these emotions rather than trying to suppress them. It's also helpful to reflect on the process that you went through while making the decision, and realize that you made the best choice you could with the information and resources that were available. Talking to mental health providers can also help work through the feelings of regret and help provide some coping strategies. And then remembering to focus on positive outcomes or moments that resulted from your decisions. So even in a difficult situation, there can be aspects that are meaningful or beneficial. Self-compassion and self-forgiveness are very important. Again, remembering that you did the best you could under very challenging circumstances, and remembering to be kind to yourself. And then regret can be a learning experience. Reflecting on past decisions can help provide insight for future choices, making you better prepared for the next decision that comes up. And connecting with others who have gone through similar experiences, sharing stories and support, can help reduce these feelings of isolation and provide advice. Again, talking about the palliative care involvement, once the regret has occurred, they can help manage it as well. So working with that ongoing emotional support, helping with processing feelings, helping reflect on the decisions that have been made, assisting in reframing your thoughts and helping to focus on those positive aspects and meaningful moments. Offering practical coping strategies to manage feelings of regret, similar to counseling. And they can also help with counseling referrals and support groups, connecting with resources and other people in the network. And they can help with the memory making again, which manages regret. In terms of clinician behavior, I'll be the first to admit that we are not always the best at enabling decision-making. There's been a big shift in medicine that, 20, 30, 40 years ago, it was completely paternalistic. The doctor said, this is what we're doing, and that's what happened. And luckily, we have shifted over to the side a little bit. So now there's a lot more shared decision making, which is difficult for some physicians to do. And also some families want more guidance and some want less guidance. And so we are sort of navigating that and figuring out the best way to help. We don't, as an ICU provider, always know a family very well when we get involved. We don't know their goals or what the potential outcome is for their child. And that's why that palliative care team involvement is a really great sort of longitudinal part of the process. And so it's important for us as physicians to help parents express what matters to them and to make room for the parents to be able to say, can I tell you whatever it is that I want to tell you about our family and our goals, and you can help make decisions that are in alignment with those goals. This is, in terms of clinician communication, a parent survey that was performed by Monica Lemon. She's done a lot of work sort of in my area within bioethics in the neurology world. But this was a survey sent out to parents, mostly mothers, and they came up with 3 big themes that they wished communication had incorporated. So the first of the themes was communicating information effectively. And basically they found that parents appreciate when clinicians offer transparent and balanced information in an accessible way. So things like tell us everything, be truthful to the parents, and provide a wide variety of outcomes. It's okay to say, I don't know. Give balanced information. It's okay to mix in positive things so that these parents can have hope. Make sure the whole team is on the same page. The second theme that they found was understand and validate parent experience, that parents value clinicians who display empathy, compassion, and a commitment to parent-partnered clinical care. So be compassionate. Compassion is king. Treat the patients and families like you were the one in that situation. Listen to the parents. They have intuition and understanding about their babies. And know that as a parent in that situation, I didn't really start to feel like a parent because so many other people are taking care of the baby. All the things the staff does to involve you in the care really helps. And the third theme was to provide support and resources. Parents benefit from emotional support, education, connection with peers, and help navigating the healthcare system. Don't forget that the parents need care too. The baby is obviously the priority, but even a small gesture for the parents goes a long way. Remember that you are constantly educating while doing your job. That must be very difficult, but try to keep in mind so you can build up these parents caring for babies with unique needs. And I would love to see a program where parents of older children connect with parents of infants to share experiences. This is from one of the previous studies we talked about, but I think it comes in well here, where they made recommendations after their survey for the clinic, where they recommended that the providers inquire the family repeatedly and actively about their wishes and needs, involve siblings, actively ask about their condition and show that you care about them, initiate and enable the fulfillment of last wishes. Realize that empathetic and clear communication is essential for the families to make conscious decisions. Show respect for the way parents take care of their child. Integrate the palliative care team early and remain connected to the family. Stay in contact with the family after the child has died. And be aware that your actions depend on your own personal attitude towards dying and death. I just was going to bring up a small point on decision aids, because I think when you have this many decisions, it can be very overwhelming. There is literature, I didn't present it here, but you know, there's decision fatigue. Parents sometimes have, you know, post-traumatic stress symptoms from making so many decisions. And so wherever we can, we as physicians and clinicians should be trying to alleviate that stress as much as possible. And even with high satisfaction and low regret, there can be decisional conflict. And so that's where these decision aids can come in. They've overall been shown to reduce decisional conflict in a variety of disciplines, but the majority of existing decision aids are on low stakes decisions, and we're talking more about high stakes decisions. And the majority of the current ones also are not designed for surrogate decision makers, which as parents, we all are. This is just to introduce this concept, nudging. So it's a behavioral economics term, and this has to do with the decision aid, but it's also my other area of interest and where most of my research has been. So nudging refers to gently guiding people towards certain decisions or behaviors without restricting their choices. It involves subtle changes in how options are presented to make a particular choice more likely, while still leaving people free to choose whatever they prefer. And so this study, looking at decision aids, showed that complex decisions can overwhelm even experienced decision makers, leading to poor choices or decision avoidance due to cognitive overload. Emotional overload can also impair rational decision making, with fear and anxiety potentially skewing the decision process. And they found in such contexts, nudges can help align decisions with patients' values by simplifying the information and guiding choices without diminishing autonomy. So this paper was from the perspective of a neurologist. And so they stated that a neurologist might first identify which factors, being its side effects, medication form, the cost, frequency of administration, are most important to the family. And then instead of listing every medication possible, the neurologist could then highlight the most suitable medications based on what they found from the family and frame discussions around those, making recommendations like most parents choose X, or in my practice, we typically choose Y, and that can really reduce the cognitive and emotional burden while also supporting autonomous decision making. So with that, I just have a couple of really brief takeaways for parents and families in these types of situations. And that is to seek support and ask for what you need. Always be kind to yourself. Remember that you did or are doing the best you could with the resources that you had or have, and try to focus on the present and the future rather than the past. And so with that, I am very happy to take any questions. I'm going to stop sharing so I can see everybody.
Thank you. Thank you, Aliza. That was very rich, beautifully presented. Definitely, in my opinion, warrants watching again, because there was so much in it. I also personally liked your slide deck with the colors. I thought that was very, very soothing. What I appreciated, and then I'll stop, but and open it up. I just want to acknowledge that what I appreciated is how when you learn what things can be, like what, based on the research, how does that inform clinician behaviors so that they can support families to reduce overwhelm and the potential for decisional regret. And then also the things that parents and caregivers can do to reduce the likelihood that they will experience regret. So coming at it from both directions. In the ideal world, you would have a palliative-minded clinician who did all the right things and helped you have all the time you needed and all the information you needed and supported you and to minimize the regret. But that's the ideal world, and we don't live in the ideal world. So I think, at CPN, what we are always trying to do is, what can we give parents? What tools, resources, background knowledge, and information can we give parents to equip them to operate in the real world? Whatever that means, in the absence of the best care available in the world, or palliative care, palliative-minded, to advocate, get information, ask for more time, things like that. So I appreciate that you named all of that. All right, let's open it up to anybody who has a question. We have some clinicians here tonight. I recognize you. Happy to see. We have parents here tonight. Recognize you. Delighted to see you. Please don't be shy. You can raise your hand or just turn off your mic and stop talking and start talking. We can also go to, there are a few questions in the chat, but let's start with anybody. If anybody wants to just raise their hand and turn on their camera and speak. No. All right, Tim, please.
Hi. So first of all, I just want to highlight that that was a very, very useful presentation. So thank you very much for that. From the standpoint of thinking about the aids that you highlighted and decision making when both parents are involved, I can imagine that there are times when, especially under acute situations, where the way in which parents are making the decision can differ from one another. So I find that that situation arises a lot. And then so what kind of strategies, I guess, have you encountered in your research that can address those acute situations where there are these differences, and how do you come to some consensus where you can start decreasing regret from that perspective?
Tim, can I ask, are you here as a clinician or a parent?
As a parent, yes.
Okay, I'm just curious. That was a great question. My personal research, I have not been able to answer that question. Some of the papers that I presented here did make brief mention of sort of parental discordance and how it obviously, I'm sure we all know that's common, right? We go into marriages or relationships or whatever type of scenario you have with the other parent of your children. And you may be together, you may not be together. That's actually something that I'm going to be looking at with my congenital heart study. So my demographics questionnaire is going to ask about relationship with the other parent, you know, married partner, non-married partner, et cetera, to try and see if that contributes. So scientifically, I cannot answer that question. And as I mentioned, I love my palliative care colleagues, and they really help us with this type of thing because they spend so much time in the rooms with these families that I unfortunately can't do. And so I think they really help tease that out before I end up sitting down for a family meeting or a care conference or something to have that sort of bigger global conversation about decisions. So I know that was kind of a cop-out answer of I'm not really sure other than talking it out.
You know, we have a palliative care team for our son, and our interactions have been great with them, and I guess that's just another resource that we can continue to use and try to maybe make more effort to talk about hypotheticals, I guess, with them more frequently.
I would,
Sorry, go ahead.
I was just gonna say, Tim, I would encourage you and your partner to be intentional about talking about what kind of decision makers you are. In a stupid example, I lived for a year without kitchen chairs at my table because my husband is one of those people that has to try everything on before he can make a decision. But intentionally talking about that as his decision process helped us when we got to decisions that were of greater stakes. So don't just assume that you're living side by side and you don't need to talk about it. I think having an honest conversation that says, this is the kind of decision maker I am. This is what I observe in you as being a decision maker. Do you agree with that? And just sort of really having a conversation I found in my own experience, and I had a child with medical complexity, helped us when we got to those acute decisions that had to be made in rapid fire succession, because we knew what type of decision makers we each were and sort of the space and way we needed to do it. That helps.
Great. Thank you.
And like Aliza said, a good palliative care doctor can be a great interpreter when the discourse between the two of you isn't quite lining up appropriately.
I could never work somewhere without a good palliative care team.
Yeah. So, Aliza, a few people, one person in the chat, Jessica, put into the chat, you know, sort of the fear of the what ifs and living in, like you're living the consequences without ever knowing, would it have been different if we'd made a different decision? And then another parent, Bella, actually had a negative outcome from a decision that Bela made. and living with that. And you do talk about, you know, giving yourself grace and forgiving. You made the best decision that you could. I'm wondering, you know, Jennifer, you and I as parents here, because this is really the burden of parenting. There's not a lot that clinicians can say about this, but how you, Jennifer, reflect these 10 years since Ben has died on any decisions, if there are decisions you regretted, and how you've made peace with them. And I'm happy to do the same, but I'm going to you first.
I think what I found most validating in Aliza's summary of some of the research is the fact that when incomplete information was provided or less than adequate for what I felt equipped to make the decision came about, that those were the opportunities where I most felt the likelihood to want to revisit a decision. And I also think in my own head, there's a difference between regretting a decision and revisiting a decision. Because sometimes I can revisit one and come out with the exact same outcome and decision that I made. And I think, as Shannon pointed out in her quote in the piece about feeding intolerance, having her husband revisit the process they went through, and I know my palliative care doctor would do that with me a lot, is a helpful thing.
Mhm.
And I don't know that I can speak to any, I mean, other than I regret that I had to work the entire time my son was alive. That was the only regret I could like come up with for his life, but that was one that I couldn't avoid because I needed the money. So it wasn't about a decision that I had to make. Do you know what I mean? Not a medical one. And I'm not sure I ever experienced sort of like that paralyzation, like I can't make a decision. I think I actually feel it more now as a bereaved parent who went through a fatiguing situation of making decisions, where now I'm like, oh, I just can't make any more decisions. But I'm not sure that's about regret. So I don't know. I think delineating the process between, do I need to revisit the decision so I can think through it and come out way feeling again like I made the right one, and then feeling a regret is different. And I think it's important to understand distinguish for yourself which is actually happening.
I really love that distinction. I was reminded of an interview that we did for CPN with two a palliative care social worker and a palliative care nurse, and I actually asked them if they had parents who told them that they actually had regret, because regret is that's a loaded term. And sometimes I think we are reluctant to call it regret because it's harder to hold when we call it regret. And the nurse said, he said, what I have had parents say is, I'm disappointed by the outcome. And I thought that was a very compassionate, kind, just a beautiful way of saying, instead of feeling guilty for the decision I made and now I regret it, I have compassion for myself. I'm disappointed that this is the outcome, because obviously I'm disappointed that this is the outcome, but that's different than regretting the agency of me as a decision maker. Chrissy.
You're saying exactly what was coming to my mind as I was hearing all of these listening to Aliza and hearing these stories. And so I'm just going to restate it in a different way that might seem obvious, but thinking about if there is a disappointing outcome, maybe we would simply call that a bad outcome, although bad isn't always the best word because that feels judgmental, but an outcome we did not want. A bad outcome does not mean a bad decision was made. So to transfer that description that descriptive word on whatever we're putting on the outcome to the decision is a sticky situation, and maybe something that simple thought that you can catch yourself. Am I moving the word I use to describe the outcome over to earlier in this sentence to the decision I made, or is there another word that I can put there, which is I made the best decision I could, but unfortunately the outcome
Yeah,
was this.
thank you. I like that. Just moving. It's not the decision, it's the outcome. Jessica, you have your hand up.
Thank you. Yes, Blythe, I appreciate you commenting on what I wrote in the chat. And just to put it into context, because I was very intrigued with the title of this class or this session. And I was hesitant to say, like, is it really called regret or, you know, semantics, I guess, but clearly everybody has the what ifs, I'm sure. But this specific scenario, maybe it is regret. It's, you know, our situation, I'll say a little bit of specifics so it makes sense, but our little boy was born without any kidneys, so we were on a complex journey to eventually get him a transplant. And he had obviously some situations that rendered him, you know, not ready for that path, right? So you ultimately, if anybody has gone through the transplant process, you have to be as healthy as possible, which always has seemed very ironic to me, since that's kind of why you need a transplant in the first place. And so he had a complication and he had a stroke. And I was in touch with another parent that we met at a hospital. Interestingly enough, this is a very rare condition, of course. And there was another baby that was born 2 months after him that was same condition, born without any kidneys. And we kept in touch. We didn't know each other. We just met at the hospital, and we would text. And I found out that her little girl had 2 different strokes. And I asked, you know, you're frantic, you're panicking, you're wondering, why is this happening? Is there any link? And so I remembered asking this when we were in the ICU, and sharing this with the team during one of the rounds. And I was thinking it would promote investigation. Like, why is this happening? Is there a link? And it could be my just assumption, but it felt like it was opposite that happened. It felt like I brought panic to the situation, and the doctors were concerned. Why is this happening? Maybe this is something we overlooked. And I always had wondered if I brought that up, did that make him, you know, delayed in his process to getting a kidney? Because we ultimately had to wait another year before he was even going to be evaluated for a kidney. It was just an arbitrary timeline that was picked. The doctor said, we're just going to wait for a year and make sure he doesn't have a stroke. And I always, you know, trying to be patient, obviously, with any medical complex situation is a challenge. And then to have to be patient, to wait for an extended year, which felt very, very random. And so I constantly wondered at that. I wondered, should we have gotten a second opinion? I wondered, did I say something that caused this delay? And so I share all that because that's a loaded context, but I don't know if anybody can relate. There's so many different things that you go over, and you wonder, are you providing information to the team to help, or does it cause an issue? Does it cause this ripple that you'll never be able to duplicate or understand if it even made sense?
No, and you won't. Jessica, thank you for sharing all that. And I'm really, really, really sorry that well, first of all, the delay in the transplant, but also that you have that worry that something you did has caused that delay. And of course, I suspect that's an impossible knowing, whether what impact, if any, you're probing questions about whether there was a connection made. And I mean, I don't think there's an answer to that, except that it's another part of the living into the, like the seemingly never ending learning to lack of answers, uncertainty. You won't know. And perhaps it's another example of what you have to, you know, put in the, that worry that you have, put it in the river and watch it float away. Because you can't do anything with that. Like you just can't. Patty, you go next. And then we do have a good question that came in before tonight that I would love for us to, any parents here will probably relate. And so before you leave, we're going to get that question in. Patty, you go first.
Real quick before Patty goes, I just want to say to Jessica also, personally, of everything that I said in that presentation, now, again, I'm not coming at this as a parent with a medically complex child or a bereaved parent, but the statement that you were doing the best you could with the knowledge that you had, I use that in my life all the time. I work with a coach. She says it to me all the time. I think it's one of the most powerful thoughts and statements that you can tell yourself because it's true. And it takes any sort of blame off the table because it's not your fault. You were advocating for your child and you were doing the best you could with the knowledge that you had. So I would say that's just the number one takeaway to have. Sorry, Patty, go ahead.
No, so I'm Patty Cantwell, actually, a pediatric intensivist, and actually kind of started what I call our ragtag palliative care team, recognizing as a younger intensivist the importance of that. And first, I'd like to thank Aliza for doing a fabulous job. And I would also like to thank all of the parents on this program, because I hope that you learned from Aliza's research, and I hope that you recognize that we are working very, very hard to do a better job in the medical realm of answering all of the things that you're bringing up. Jessica, my heart breaks to hear the stress that you had. I am at a quaternary care, critical care center that does transplant. And Aliza brought all of this up, but I live every day with medical teams not on the same page, with like the ICU teams not being on the same page with the specialty teams. I watch how fragmented medical care is, that you feel like my general pediatrician that's supposed to organize all of this stuff doesn't even hear about the subspecialty things. And so I thank Blythe and Courageous Parents Network for the resources that we can provide to families to try to at least give them a sense that we are working on this. And I assure you that we are working very hard to improve our communication so that we bring to you what it is as families that you need. And I think what I hope that every parent that's on here that's lived with a child with a complex condition of any kind, I heard not long ago someone talk about the ODTAA syndrome. And any parent that's had a child with a lot of issues has had this. It's one darn thing after another, because we medical teams often will make a recommendation in our thinking that this is the right thing, and then it doesn't turn out the way that we had hoped that it would. And as a parent, I cannot imagine how challenging it is to be living with the ODTAA syndrome, but you are doing your best. You are advocating for your child, and we encourage parents to be that advocate and be what I hate to hear is the difficult parent, because there is no difficult parent. You are advocating for your child, and keep doing it, because you will find someone who will listen. And I'll stop. But again, thank you.
Thank you, Patty. Love that. See? And people will watch this and hear, and it'll be part of in the zeitgeist. Before we adjourn and thank Aliza and all of you, I do want to say that one of a very I think resonant question came in prior, which is how to handle. You've made peace with your decision. You've made the decision. It was a difficult decision. Lord knows there probably was a huge amount of conversation, information gathering, revisiting that goes into the decision. You make it. And then other people question your decision. And they question it again and again and again. And whether that's your extended family, another clinician, a friend, how to handle that unsolicited feedback about a decision you have made. I don't know if any of you can relate to that. Jennifer and I were talking before we started tonight that, you know, my instinct would be to gently say, this is my child and a lot of effort went into this decision. And I would ask you to please respect the decision. This is the best, most loving decision that we could make for our child. And thank you for respecting that. We welcome any other thoughts or feedback that one might offer to somebody who's deciding to revisit that decision on your behalf. There's a lot less tactful things you could also say.
Blythe, I met with a mother this morning in my practice who shared something very similar. And she said, I have a new line. This really happened today. She said, I have a new line. I heard it from other moms and I had the chance to practice it recently. And I was like, okay, what's the new line? She said, my new line is be happy in your ignorance.
That's very good.
So she said, I tried it out and it felt kind of good.
Yeah,
That one
that's
worked.
very good. That's very good. That's very good. It gets a lot communicated in just a few words. I have a friend who's told me that when she uses the line, and this is not in the context of parenting, but just generally, I find it so interesting that you feel that you can say that to me.
Mm-hmm.
How interesting that you feel that you can say that to me, and then like shuts them up.
Yeah, I think those kinds of lines are very effective and very helpful. But I also want to acknowledge the reality is that they don't help you late at night when you're thinking about the interaction that you had with the person. And that's when the doubt comes creeping back in and the opportunity for sort of that seed of regret to build up inside of you again. And so I would just say, and I said this to Blythe earlier, is we try at CPN to remind parents that this is your story, your reality, your realness, your choice. And you can say it, tell it, believe it, know it, and own it because it's yours and it isn't that other person's thing. So when they go to self-doubt give them the hard line, but go home and give it back to yourself and remind yourself again, as Aliza said, you did the best you could with the information you had. And that at the end of the day is the right thing. And so remember to sort of give the line back to yourself in a way. Do you know what I mean? Like just pull yourself up and remind yourself that you are doing the best that you can, because it feels really great in the moment, I think, to tell the person, the middle finger or whatever it is you want to do. But at the end of the day, you have to go home with it. So just remember, you are doing the best you can. And as Aliza pointed out, regret is only something we can know in hindsight, and it doesn't really necessarily do us any good to look back at it.
It doesn't do us any good, except if it informs future decision-making. Next time I will ask for more time. I will ask for more information. I will ask for palliative care. I will ask for a different something or other. That is the only reason to sit to look at the regret, is to see how might I do it differently next time.